Good morning. Now, Mr. Connell.
We have one witness today, my Lord, Sandra Devine, sometimes referred to in emails as McNamee,
Right.
in the early days.
Good morning, Mr. Devine. As you understand, you're about to be asked questions by Mr. Connell, sitting opposite you. But first, I understand you're willing to affirm. Sitting where you are, would you repeat these words after me? I solemnly, sincerely, and truly
I solemnly and sincerely
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Now, your evidence is scheduled for both this morning and this afternoon. We will take a break at about 11:30 for coffee. But if, for whatever reason, you wish to take a break at some other time, just give me an indication of that and we'll take a break. Something I say to most witnesses, partly because my hearing is not absolutely great, is that I need to hear you and the room needs to hear you. So could I encourage you, it's not necessarily straightforward, but could I encourage you to speak maybe a little louder than you would in normal conversation, maybe a little slower than you might speak in a normal conversation, because others in the room are keen to hear what you have to say and note what you have to say. The microphones should help, but I would much appreciate that if you were able to do that. Now, Mr. Connell.
Thank you, my Lord. Ms. Devine, you've provided a statement to the inquiry following a questionnaire and answers to that. Are you content to adopt your statement as evidence of this inquiry? Thank you.
Once again, Ms. Laurie, thank you for the contribution. I didn't hear it, but others will have done so. Right. Is the screen now? The screen is now visible.
At least that one is, yes.
Right.
That's fine.
Okay. We're not immune from technical problems.
Yes.
Mr. Connell.
Thank you. Your background, as you fully set out in your statement, is originally as a nurse, from which you progressed into various posts, and in 2009 you became the Associate Nurse Director for Infection Prevention and Control, and then in 2019, on an interim basis, the Infection Control Manager. Is that correct?
That is correct, yes.
And you're currently in the position of Director of Infection Prevention and Control for the board.
That's correct, yes.
You very helpfully set out in your statement quite a lot of information about structures and governance and so on. I'm not necessarily going to ask you orally to go through all of that because it becomes a little tricky, I think, to take orally. But before we go to your witness statement, which I'm going to use essentially as a guide to take us through today's evidence, and I'll be referring to passages as we go. I wonder if I could just take one or two general things from you. At various points in your evidence, you're very careful to point out the restrictions on your ability to offer comment on various matters. For instance, you say, well, I'm not a microbiologist. I'm not qualified to comment on ventilation systems. You didn't have particular knowledge of water microbiology. And you use these to restrict your comments in answer to questions that you're asked. Now, I suppose I just wanted to ask you a general question before we go into the detail. That being so, why is it that we find at various points of the, let me just call it a saga for the moment, that you seem to be challenging people who do have these qualifications, who are microbiologists, in fact, consultant microbiologists, who are familiar with ventilation in the built environment and who do have knowledge of water microbiology. Why do you find yourself, as it were, challenging the views that they're expressing?
I mean, I don't really consider asking questions and trying to clarify for my own learning and knowledge a challenge. I mean, I work with infection control doctors and nurses, as you know, at the moment. And it's always been a collaborative process where we learn from each other. So I know others may have pitched that as a challenge, but I think in order, and sometimes I will ask essentially the daft lassie question in order to clarify maybe a point for a room, or and also for my own knowledge. So I think I would probably say that it is my role to be inquiring, and I learn from the microbiologist, and I hope that they take some learning from infection control nursing service as well. So I know it may seem like that, but I have always had that relationship with microbiologists and infection control doctors where I ask a question and, for my own clarity.
So they sometimes may be perceived as you challenging them.
I don't believe that's the case with the vast majority of my clinical colleagues.
Another general question. We'll come back to this a little later about how things are meant to work. But the phrase nurse-led crops up on occasion. And I'm just wondering whether you can help me on this point. If the infection control doctors don't think that things should be nurse-led, and you do think that it should be nurse-led and encourage your team of nurses to follow that line, could that be behind a number of the areas where there appear at least to be conflict?
I don't believe it's a nurse-led service. I don't know who first spoke about it being a nurse-led service. It has never been a nurse-led service. We are a team. I've always worked in a team. I've worked in many areas with microbiologists and infection control doctors, and it can't be nurse-led because the two things have to complement each other in order to take action. So I'm not clear where that came from, but I have never considered it to be a nurse-led service. It's it's mainly nurses. So my team is about 50 strong, and probably about 35 to 40 of them are nurses. And we have a team of infection control doctors, but we also have clinical scientists and healthcare scientists, surveillance staff. So I have never considered it to be nurse-led. So I'm not sure where that has come from.
No, so if an infection control doctor didn't think it was a nurse-led service, that wouldn't be a criticism of them, because you would say, no, it isn't.
I don't believe it is, no.
The other point of a general nature, I'm trying to pick up one or two points that recur.
Yeah.
Is that at various points when issues or suggestions as to what do we do now or whatever it is are being discussed, you say things like, well, the clinicians were concerned. And then you say you never ignore the concerns of clinicians. Yeah. So in many cases you say, so we didn't do whatever it was because they were concerned. At some points of this exercise, there sometimes seems at least to be a situation where the infection control doctors feel they have the support of the clinicians, yet are being challenged by people like yourself. Now, that doesn't kind of square with the idea of supporting the concerns of clinicians, does it?
I think I always support the concerns of clinicians. I suppose for context, because I believe I can understand where you're going. There is an infection control service. But so just for context, so we take across into our systems about 40,000 referrals a year. Right? So 40,000 patients are referred into our systems, and these patients are assessed and advice is given to clinical teams in order to try and look after these patients. I have a responsibility to make sure that all patients across Glasgow and Clyde, with 6,000 beds, have the same access to the infection control team and infection control services. And, you know, there are times when I would like to do everything for every patient, but that is not possible to do. I mean, we work with the resources that we have, and we are a very well-resourced team in terms of comparators across the UK. But there are times when it would be nice to do something, and I would absolutely do everything I can in order to make that happen. But sometimes everything we do in healthcare has an alternate effect, right? So if you do one thing, you're not doing another. And so it's my responsibility to make sure that that's evened out across the patch. So sometimes I would love to do line surveillance everywhere, but it's intensely resource intensive, and you do where you think the greatest impact is going to have for your services. So I understand that there might have been asks of the infection control team that we haven't been able to fulfil properly or as much as we would like, but that's a judgment that we're making all the time in terms of where we put our service.
Thank you. I think I'll now have a look at the witness statement so we can work our way through. You'll find that not every question you've been asked is in strict chronological order, so we just need to cope with that as we go. If we go to 396, and you'll find that there's electronic numbers at the head of the page, which will come up on the screen in front of you. I'm not sure whether you're work from a paper copy or an electronic copy. But I'm on 396 in paragraph 11, near the foot of that page. I just wanted to ask you very briefly about that. What you're describing there, as I understand it, is what's called the senior management team. Now that's you, the infection control manager, when you weren't the infection control manager, and then the lead infection control doctor, is that right?
Correct, yes. And
they're described as a senior management team. Does that mean they're responsible for managing the process of infection control?
Well, as I say, it's my responsibility to make sure there's an infection control service across the board. It's also my responsibility at the moment to direct and directly manage that service. So in this context, at this time, I would have been the lead for the nursing and the surveillance service. So I would have managed all of the nurses' surveillance service and everything they were doing at the time.
Is this not a team that's supposed to manage between them the whole thing?
But we do. So I do at that point. I would do the nursing part of it. I think it would have been Professor Williams in the first instance, and then Dr. Ingster. They would have managed the function of the ICDs, and Tom would have been the infection control manager. So he would have had oversight of the entire service.
Yeah. And Mr. Walsh is the one that wasn't an infection control practitioner.
Correct.
But you don't manage it together. Do you just manage your own little bit? Is that how you're saying it works?
We come together, and we come together to manage the services in its entirety. I mean, it's a service where the nurses will do a lot of the kind of frontline liaison with clinical staff. But for example, if there is an incident or an outbreak, obviously the infection control doctor perhaps at the site or the lead and I would come together, and any actions that were taken would either be part of the doctor's role or part of the nurse's role. So it was a collaboration. So Tom was manager of the service, but I mean, we did things together. I mean, we didn't do it in silos apart, and we had an SMT meeting where we all met together. We do that now every week, and we bring to the table shared learning and issues that we're trying to resolve, and we come together and try and take a collaborative approach to any issues that are being raised.
I want to ask you about a couple of other organisations just very briefly to see if you can assist us at all. Yep. If you go to electronic page 402, paragraph 22 of your witness statement, there's a reference at the top of the page to the AICC, the Acute Infection Control Committee, and we know there's also a BICC, a Board Infection Control Committee.
Yeah.
Now, we've had a lot of evidence from a lot of people since this inquiry started, and the fault may be mine, but at the moment, I can't think of any example of either the AICC or the BICC actually doing anything. You hear of them having reports or having meetings or noting events, but all of the actions seem to be taken elsewhere. Can you help us about that? Is that not something they do?
Well, they have oversight. So every year I prepared an infection control programme and a work plan. So the programme and the work plan are based on our responsibilities in relation to standards and policies that come from the government. So in that work plan, it will say what the issue is, who is the lead for that issue, and what we plan to do about it. So these, although they're reports that go to AICC and BICC, these detail the work that has been done across the piece. So the work plan is there and is visible, and we're asked to tell when the work plan is slipping or when we've achieved things, so they're complete. So there are pieces of documentation that go to AICC and BICC that describe the work that the teams do. We also, I mean, it is quite a big agenda because, you know, there is a lot.
I can understand, so I'm sorry to interrupt, but I can understand you make a number of reports to them and you put material to them. Can you tell us any example, you know, you lived through the issues, and I'm just using as a neutral term, at the new hospital from 2015 right through the progress of matters 2019, 2020 and so on. Can you give us any example of the AICC or the BICC actually instructing or ordering or intervening in any of the events that happened?
I mean, I don't think that's the function of AICC. I think the function is oversight and for us to give assurance that we're doing things. So if there's an incident or an outbreak, we complete the hot debrief tool. And within that, there's lessons learned. And AICC has clinicians from each of the sectors on it. So we're trying to share learning around those lessons. And it's entirely possible that someone might say, oh, that happened at the Royal and we've done that. And we share lessons across the piece. So it is a forum where there is a lot of papers, and the intention is that people look at papers, what are you doing about this, and ask questions about it. So although you might think that the group doesn't do anything, I think the governance groups are about oversight and us giving assurance that we're taking things forward.
Well, can I ask you about another governance group which appears on the same page of the witness statement in paragraph 24, the Clinical and Care Governance Committee? Because to an outsider, having explained what the AICC and the BICC are, here's another committee which seems to be not dissimilarly named. So how does the one committee relate to the other?
I mean, it's an escalation process. So the Clinical Care Governance Committee will consider clinical issues right across the board. So it could be how the pathology service is delivering a service, perhaps a new initiative. It will have a look at it will review the output from the acute clinical governance group, which will detail any issues that might be within acute care that has been raised. So the governance is almost a filter. So the governance systems within GG&C is, by the time it gets to clinical care governance, that will be looking at governance and care in its broadest sense, including partnership areas and primary care. So it's that group has a quite, a large remit.
Thank you. Just a couple of things I want to pick up briefly in passing through your witness statement. Can we go to 405 to paragraph 33? Just so I'm getting this correctly, the point you're making there is that you've changed your standard operating procedure for outbreaks following the recommendations from the Oversight Board. Is that correct?
That is correct, yes.
If we then go on to page 406 in paragraph 36, where you note that when you were first in the role of nurse director, Professor Williams was the lead doctor. This is why I asked you about how the SMT worked, because we've had quite a lot of evidence about very significant issues encountered by infection control doctors and those who were asked to become infection control doctors and were basically saying no universally. And you, I think, say in your witness statement that you sort of knew nothing about any of this, any of these problems. How can that be if you're working as a team?
You know, I understand. I suppose not aware is not probably the right term. I mean, within professional groups, you will get a bit of competition and challenge. When I was Associate Nurse Director, which I was up until 2019, my primary focus was in making sure that the nursing team were working well together, were working with the ICDs. I don't think I had a full awareness, perhaps, of the issues that were present, I think specifically within the South sector. So again, obviously I'm covering the entire board area. There was never anything that was brought to my attention from any of the microbiologist ICDs in the Clyde sector or in the North sector. So it did seem to be an issue with the South. Now, when you put labs together, so when I first was infection control nurse, there was a lab in the Royal, a lab in the Western, a lab in Stophill. So when you're putting these labs together and you have these kind of quite big personalities and clinicians, you will get a degree where they may not agree. But I can honestly say it wasn't until I was asked to attend the meeting with Dave Stewart that I really had any sense that that perhaps Professor Williams wasn't getting on as well as he would have liked to with the other infection control doctors. I'd probably like to say as well, if I may, that the current team have been working together since 2019 and all work collaboratively together. We'll work well together and there are no issues with that team, with our team.
Can I just move on then from that point? We pick up the Dr. Stewart meeting a little later on. First of all, just for identification, I just want to pick up one reference you made. I asked you a short time ago about the Clinical Care and Governance Committee, and you helpfully tried to assist us with an explanation of what things that might come to it. If we go to page 414, of your statement in paragraph 63, we find that committee mentioned. Now, I'm not sure we need to dig that document out, but am I right in thinking that what's being referred to there is the action plan following concerns raised by microbiologists, and that ended up at that particular committee?
I believe so, yes.
Thank you. And again, this is probably just in terms of picking up a few details. If we go to 419, I'd quite like you to help me with a phrase that you use in paragraph 81. We've been talking in this section of your evidence about standard operating procedures, and you note in paragraph 81 that the recommendation from the Oversight Board is to phase out local guidance and refer to a manual. And then you say you've been gently migrating towards it. Perhaps you could just help His Lordship with what you mean by gently migrating.
So I was a nurse consultant for a while, and we used to come together as a nursing team and put together local policies and procedures. We were actually advised that they probably weren't policies, they weren't SOPs, so we changed it to SOPs over time. But we had a manual before there was a national manual, and people were very proud of the work and the effort that went into to producing that manual. So there was a subgroup of the BICC which specifically drew up these types of protocols and SOPs. And like I say, they were very proud, and you know, we thought they were more locally relevant. I was very aware that we had a national manual, but you know, people liked their local SOPs. So when I say gently, I was kind of persuading specifically some of the senior nurses to perhaps go towards the reference to a national manual rather than have our local bits and pieces. So that's why I meant gently, sorry.
Can I just check that I've got things right? There has been the National Infection Control Manual available since, I think, 2014?
Yes.
And it was updated, I think, in 2022.
It's updated all the time,
Right.
yeah.
And when you're contrasting that with local standard operating procedures.
Correct.
And what we're talking about are things of a very practical nature, such as hand washing regimes and the like. Right, thank you.
The national manual is a great resource, and it has literature reviews that back it up, but the sections are in slightly different places. So if I'm a nurse in a ward and I have a patient who comes in who has perhaps salmonella, just, you know, you would have to go into different sections of the national manual to have a look at SIPs, isolation procedures, incubation periods. So what basically the infection control nurses in Glasgow and Clyde did was they put all of that information into a single SOP,
Right.
so that you didn't have to kind of navigate your way through the national manual. And we felt that, especially out of hours, if you had everything that you needed within a couple of pages, it might be more, it might be easier for frontline clinical teams to refer to it rather than using the national manual.
Thank you.
I think it might be then appropriate just to pick up the same reference in page 422 of your witness statement at paragraph 89, where again you refer to the national manual and SOPs, and in fact we see the dates of the national manual quoted in bold there, so that's an easy reference. The one point I did want to ask you about this, just so we understand on the inquiry what you're saying, is that further near the bottom of the page, you say, well, we define what a problem assessment group is, what is an IMT, and then you say it asks members of the IMT to consider that if there are risks that cannot be addressed in the IMT process, these should be considered for inclusion in the IPC or services risk registers. Now, can you help us understand what kind of things might not be capable of being dealt with in the IMT, so we know what you're referring to here?
Well, as an example, we recently had an outbreak of MRSA in the burns unit in the Royal Infirmary, and there was an IMT process, put controls in place, screen patients. There's a whole list of things we might do for that type of outbreak. But one of the recommendations in the hot debriefing from the IMT was that the ventilation system within the burns unit should possibly be reviewed and upgraded, just because these patients are not nursed in what you would imagine a specially ventilated area for a burns unit would be. So one of the things that we have asked them to do is to put that on the risk register and escalate it through governance in order that that area might be able to be prioritised for an upgrading ventilation system going forward. So it would be sort of fairly large things that an IMT isn't able to address.
Well, maybe my fault. Let me try and unpick that answer if I can. I can understand that you have the outbreak, you take steps to deal with it.
Yeah.
One of the conclusions is there's at least a question mark over the ventilation. Could it be better?
Yeah.
Should we do something about that? And I can understand that a recommendation needs to go somewhere else for that to be done. Presumably states have to be involved and so on. But where does the risk register fit into that process?
Well, so if I was a director of the Royal Infirmary, what happens is the services have their own risk register. So you might find that the burns unit in itself will have its own risk register, and on that would go that ventilation recommendation, and then it's scored. So they would do that as a service and say, we think this is quite a high risk. So the scoring system would be, say it was 20 as an example. All the risk registers for the service within that sector would be reviewed, and any that scored high risk would go on to a sector risk register, and then it can go all the way up to the board. So it's a process where services have risks, and then they're escalated so that they're within the context of maybe a sector risk register, and then it goes all the way up to the board risk register. So it's a way of identifying an issue and then trying to place it within the context of different risks.
So it's not simply a question of the people concerned with the burns unit saying we need better ventilation and going to somebody and saying,
no,
give us it.
It's a way of highlighting that this is something that we would like to do, but it gives the context of what might be possible. So the burns unit might like ventilation or an upgrade to ventilation, but say the ITU didn't have the right ventilation, so somebody would have to make the decision about what is the greater risk there, and then it would be prioritised in terms of actions, and absolutely estates would have to be involved in something like that.
Which might be a slightly frustrating process if you were the person who'd made the recommendation at the IMT, because you would think it was disappearing somewhere into a sort of process-driven world.
Yeah, no, I mean, I understand that. It's just trying to balance the relative risks. I mean, in health, risk is a dynamic process. So the burns unit, that might be a risk today, but they might have another large outbreak of MRSA where patients have been significantly affected, and they might feel then that risk is increased, and that risk assessment will have changed. So everything in health is about balancing risks and also the consequences perhaps of things that you might do. So almost everything that we do has a consequence that we might not have thought of. So I mean, if I give a patient, or if a patient is, try to think an example, prescribed an antibiotic, that will alter their natural flora, might make them more susceptible to something else. So, or if your patient has that needs a proton pump inhibitor, which takes down your gastric acid, you need that because, say, you have heartburn, but actually by doing that makes you more likely to have C. diff, for example. So it's almost like everything we do usually has some kind of counter to it. I'm sorry if that's not clear, but I'm just trying to say the risk thing is.
I'm just wondering, to stick to your example, what is the risk of the burns unit getting its better ventilation being balanced against? You instanced the example of, well, if ITU needed ventilation and there was no money, presumably, that they would need to get it first, but not immediately obvious what you're balancing this risk against. The risk has been identified, you not just fix it.
That would be wonderful. I mean, it would, but it's not like that in the NHS. So it's scored in order to try and describe that level of risk. And I mean, I probably can't explain it much more than that. I have risks in my risk register that we score and then the highest risks go forward for consideration with other services risks. And then, you know, another group of senior staff will have a look at that. And then, I mean, it's just the way, it's just how it operates in practice.
And the net result of that process, if I'm picking it up correctly, is that risks that have been identified perhaps by clinicians are not actually actioned because they don't score high enough in comparison to other people's risks.
I mean, I don't agree with that. I
No?
mean, everything, we're actioning things all of the time. We're upgrading ventilation all of the time. There might be a new service that comes in, like a surgical service, maybe some kind of innovation, like, I don't know, maybe, you know, we might get a government, in fact, I think there was a letter come in just the other day about vaccines, and RSV vaccines for elderly patients. So that might come in and that will require resource, and not doing that will have a risk. So it's dynamic and it's complicated to understand, but health is a complicated system, and there has to be some way of everybody's voice being heard in terms of risk in order for decisions to be made about how they're going to address those risks and what risks might be more than others.
Yeah. So if I just take the very end of your answer there, some risks might be more highly scored than others, or whatever the right phrase
Absolutely,
is.
yeah.
And therefore they will get priority, is that right?
Yeah.
And the others will not
No,
at that stage.
yeah, so what happens is you're reviewing your risks all of the time. So I do it every quarter, and things might change and the score might go higher, or you might have a risk that's been addressed, in which case the risks that are underneath that might become more prominent. So I'm really sorry, I'm not a risk manager. I couldn't completely describe the entire process to you, but that is the process that we work with in the NHS. And I think you'll find that in every board.
Thank you. Let me ask you an entirely different question. You refer to Dr. Teresa Inkster at various points in your statement, and certainly in the earlier parts of your statement, you're really quite positive about her. You say you respected her, you say you had no problems with her becoming LICD, and so on and so forth. Is that correct?
Absolutely.
And you felt you worked quite well with her?
Yeah, I worked with Teresa in the Western when she was I was the lead nurse for West Glasgow hospitals, and Teresa was, I think she was a senior registrar in West Glasgow at that time as well. So I had worked with Teresa on and off for quite a long time.
We'll come back to that, no doubt, later. Just for completeness, on page 428, paragraph 108 of your witness statement, we see there, you say you were aware that Drinks had been off on a period of sick leave. She was unhappy about certain conversations and she resigned, and then I think we may have heard that she was persuaded to come back. So that would be something that would be bothering you, presumably, if your much respected colleague was unhappy enough to step down. Is that right?
Absolutely, yeah.
Now, in the next section of your witness statement, you're dealing with issues such as reporting structures. And I just wanted to make sure I'm not misunderstanding one of your points. In paragraph 109, you explain circumstances under which you and Mr. Walsh, or you and Mr. Walsh and Dr. Inkster, or Mr. Walsh and Dr. Inkster would go off and see Dr. Armstrong.
Yes.
I'm paraphrasing what you've said. And then you appear to be making some kind of criticism in paragraph 110, where you say, I think Dr. Inkster thought that because we went together, she had a direct line to Dr. Armstrong. Is that a criticism of her you're making there?
No, that's just my understanding.
Because if you go on to the next page on 429, you say in paragraph 113, I found when working with Dr. Inkster, she would often quite informally go to Jennifer directly, as would I. It could be any of us, and we normally did this collaboratively. I considered an effective way of working. So there'd be no criticism of Dr. Inkster for going to Dr. Armstrong, would there?
No, none.
At least not from you.
No.
Thank you.
We had different skill sets. So I could probably do an update in something like an MRSA outbreak, but absolutely if it was something like, you know, like the water incident, it's better. Teresa would have had much more of an analysis of what was going on and what actions was taken. So it was almost like a process, like if it was more kind of nursing type actions, I would probably do the update, but or sometimes I would just speak to Teresa, or she would speak to me, and we would collaboratively do a briefing for Jennifer. It wasn't I'll do that and you do that kind of thing. It was a process where we worked together in order to get the right information to Dr. Armstrong should it be needed. I mean, it wasn't a demarcation of anything. It was simply I would meet Teresa and say, you know, Dr. Armstrong's looking for a briefing on that. Do you want to do it? Do you want me to draft it up and I'll send it to you? So it kind of worked in a kind of harmony like that.
In your witness statement at 432, at paragraph 124 onwards, we're touching on this thing called triggers,
Yes.
which are part of the process of triggering either a PAG or an IMT. Is that correct?
Yep, that's correct.
Did you have differences from Teresa Inkster on what the triggers should be?
Right, so the triggers were put in place by Dr. Inkster, and that's just a thing that happened. So I mean, that I didn't have any problems with the triggers we had. These environmental organisms that had been added into the manual, and really there wasn't any guidance in how we would carry out surveillance round about these particular organisms. So to a certain extent, we were in the dark. Now, normally, in some of the areas where they were bigger, we would have used the SPC charts in order just to monitor trends over time. But actually looking at retrospective data with SPCs can be quite difficult. You're better to do these in real time, but it takes 2 years, over 2 years, before you can get all that information in.
Can I just ask you to pause just for a second,
Sorry.
so that his lordship get what an SPC is, please?
Sorry, a statistical process control chart.
And just tell us what that is, and then I'll take you back to where you were.
So it's literally a graph. It's only numerical, so it's only numbers that are counted, and it gives you a trend over time. So as long as the trend is within the control limits, it looks like natural variation. So you might get 3 cases of C. diff 1 month and 2 the next, and that would be natural variation. The SPCs are set up so that if you breach the upper control limit, it tells you that something unusual is going on. It doesn't tell you what it is. It just says it's a trigger for action. It says, go and have a look at this. Something has changed. Your numbers are higher than you might expect. So we use these types of charts for C. diff and MRSA over many years. So that's...
Am I right in thinking you need a minimum number of data points in order to
Yes,
set up your graph?
Yes.
And when you use the word unusual, there's a certain circularity in that, because your graph defines what is unusual.
Yes, it's usually 3 standard deviations from the mean. So statistically, they'll say if your numbers fall within a higher than expected level, then you should go in action. Sorry, I'm not an epidemiologist, but it's about unnatural variation, so something that you wouldn't expect based on your historical data.
And of its nature, it's a way of looking at things which you expect will happen. Am I right about that?
Yes, so it will give you a background rate. I mean, you don't want any patient to get infections, but unfortunately patients do have infections, so it will give you perhaps what you might expect to be a normal background rate.
Not so useful in relation to events that you don't expect.
No.
Right. Thank you. Well, just so we deal with this question of triggers while we're there, could we look at bundle 27, volume 8, page 120, please? If we just look at the email in the middle of that page, this is an email from you to Tom Walsh about triggers. And it appears there that you're saying, well, Teresa's opinion is that these are associated with water, these are the gram negatives. So the IMT process is commenced as normal. Is that, are you disagreeing? Is that part of you disagreeing with Teresa Inkster or not?
No, absolutely not. I think I did see this email. It might just have been yesterday. It's not, it's just me simply reporting that the IMT process is starting, why it's starting. I think in particular with this one, it was, if I read down that email properly, it was CNO had instructed that we had a different process. So the only reason I would have emailed that and said that perhaps we should share it with Jennifer and Mags was that we were getting instruction from the Scottish Government to change a process back again. So no, I didn't disagree. I mean, Teresa was the lead ICD. She was running the IMT. If Teresa thought that two organisms in a 2-day period was, or a, you know, whatever period was a concern, then that I wouldn't have disagreed with it.
Thank you. If we go back to your witness statement, we go back to page 433. Again, I'm using you as a means of making sure we understand certain things. And one of them is something called the point prevalence survey. Now, a couple of things about that. First of all, in principle, this is something done every 4 years.
Correct. Yeah.
So it no doubt provides useful information, but as his lordship put it, maybe not very good at dealing with unusual things that happen in the meantime. Is
Absolutely.
that right?
That's correct, yes.
And am I also right in thinking that what you say in paragraph 128 is that the focus of these surveys is traditionally on patient-to-patient infections? That's really what they're traditionally looking for.
I think I see traditionally our focus is infections that have the potential to go patient to patient.
Yes.
So the point prevalence study, it really is a study that informs government policy. So, but it would look at patients and all of the patients in all of our wards once every 4 years, but it includes things like respiratory tract infections, urinary tract infections. What I'm saying is the focus of infection prevention and control over years has traditionally been the types of infections that would go patient to patient. So things like Clostridium difficile, SIDA, Salmonella, E. coli. So the point prevalence study is the only time when we actually have a sense of the burden of healthcare associated infections. So at any point in time, based on previous point prevalence studies, about between 4 and 5% of all patients will have some kind of hospital acquired infection. We don't know that as a team because that kind of information is only done every 4 years because it's so resource intensive to do it. So the focus traditionally of infection control teams is to prevent infections between patients of the same organism generally.
And I think I'm right in saying that so far as the period that this inquiry is primarily concerned with, there was a point prevalence survey done in 2016, but then for other reasons it wasn't done in the next section, presumably at least in part due to COVID. Is that right?
That's correct, yes.
And all it identifies is how many infections you've got, but not how. Is that right?
Correct, yes.
Yeah, because that's not what it can't do that.
It's just a measurement. It is to drive policy. So I think the last point prevalence study, there was a high, if I remember correctly, I think the most common infection was catheter-associated urinary tract infection. So there was work streams that came from the Scottish Government about how we can try and drive down the rate of catheter-associated urinary tract infection. For an example, my understanding, if I remember correctly, is they collect quite a lot of information about antimicrobial prescribing, and again, that's used to develop policy in terms of antimicrobial governance or stewardship.
Thank you. Now, you very properly told us another thing you're not is you're not an epidemiologist, and therefore I restrict my questions to you on this point. But in your witness statement 435, in paragraph 135, and this is unfortunately where the witness statement is not all, and it's our fault as much as anybody's, it's not all in chronological order to events that we'll otherwise come to, but you describe there wanting some baseline data to see how you were performing for key indicators. Now, the key indicators that you mentioned there, that's what, C. diff and Staph aureus, and the other one is?
E. coli bacteria.
E. coli, yeah. And apologies if I'm using shorthand for the full name. So not the infections that are the ones that we've been talking about on other areas. And that was all you could get. You could find out how the hospitals were performing, you were told, on these indicators.
It was just to, I think, give a sense of whether or not the hospitals were outliers with any available indicators. So in the absence of having anything specific, was there anything that would draw your eye to the hospital being some way out of kilter with the indicators that we had? So, I mean, that's why we asked for, so we get board information, and obviously if you're in smaller boards, it might be more meaningful. So we asked RHI if they could do the indicator specifically for QE and RHC, just to see if for some reason, because we're getting board data, perhaps they were outliers in any way.
And you understand that the hospitals used for comparison were older hospitals?
Yes.
And then on page 436, you're asked whether comparing the still, I suppose, brand new Queen Elizabeth Hospital with, and excuse me if I say Queen Elizabeth Hospital, I'm including the children's section, just save us using the full title every time. You say, is it fair to compare a new hospital with an older hospital? And your answer is, well, not in relation to C. diff, but the others are a bit more complicated. Is that right?
That's correct, yes.
And in the next paragraph, you say, well, shouldn't a new hospital be doing better? And I think in part you agree with that, because you say, well, given how it's set up, particularly with the single rooms, we should be reducing infections from patient to patient. I think that's what you say in paragraph 138.
Yes.
And can I just ask you this then? That's dealing with the patient-to-patient transmission. But if you have a hospital that's supposed to be state-of-the-art, picking up all the lessons from the past, best design, etc., should they not be producing better results across the board?
I mean, the hospital is only one factor in terms of preventing infection. So I think that I try and say, so the environment is important, but as long as you have to put lines into patients, so plastic into people's bloodstream, as long as you have to perform surgical procedures, it's not as binary as that kind of direct link. You would absolutely, in terms of person-to-person type infections, expect a single room accommodation to make a great impact in these types of infections. But in terms of things like E. coli bacteremia, that's about how we manage patients' lines, for example. So that should be the same regardless of your environment. So it's not as connected is I'm not explaining that very well, but it's one factor in amongst probably a complex number of factors.
But at least the environment should be giving the teams working there the best possible chance of reducing the infections. You quite properly say it's unlikely you'll ever get them down to nil, but you should be trying to reduce them.
No, I mean, absolutely. I mean, during COVID, I approached RHI for some data around about hospital-acquired COVID cases, and it was for the 3 big hospitals across the board, so the Royal, RAH and QE, and not unexpectedly, the QE did quite well in that analysis compared to some of our older facilities. So in terms of things like respiratory infections, then yes, you would expect that, and that's what was reported.
Sure. Can we go on, and probably only need to deal with this briefly, to 440, where we're coming back to the point that I probably asked you in part already about culture, because you're in effect saying in paragraph 150 that you weren't aware of a lot of the issues until you met with, among others, Dr. Stewart, and you said you hadn't seen any problem. I mean, were you and Mr. Walsh contributors to the problems that the ICDs had?
I don't believe so.
Because you say in paragraph 151 on page 441 that you consider the infection control team have always interacted well with microbiology.
That's correct.
Not exactly the picture that you paint later in your statement, is it?
So I have been working within infection control for, as it say my statement, for 30 years. I've worked with microbiologists in the Royal, in the Western, in Stockhill. I work with microbiologists infection controls all over the board now, and have what I consider to be a really positive and collaborative relationship with all of the team, including the ICDs that currently work in the QE. There was certainly a point in time when that didn't work as well.
The reason I'm asking about it is that you say on page 442 that you, and I think by that you mean you and the nurses, felt that your actions were being questioned and you weren't being supported. And that's in effect the complaint that the ICDs were making, that they felt they were being questioned and not supported. So somewhere in there, your impression of collaborative working might not be correct.
Again, for the vast majority of the time and the vast majority of people, I still say that we work well together, we work collaboratively together. There was a point in time when it didn't work so well. So, I mean, Dr. Peters was appointed in 2014 and was, you know, a really good ICD actually. I mean, really knowledgeable, very focused and hardworking. But the issues that arose in that, it was difficult to work in that kind of team dynamic there. So when Tom and I first came into post in, I think it was 2007-8, the board, right across the teams across the board, had been in separate hospitals for a long time and had come together and had very different practices and how they managed their systems and processes. So, for example, I worked out of the Western, and we used an APInfo. It was a freely available database that I think came from the CDC in the States, in order to manage our patient load and try and do some analysis of our data. In the Vale of Leven, there was cards up against a wall with patient names and some notes. So there were very different systems and processes across the piece. So we spent, I think, probably the first 3, maybe 5 years ensuring that the systems and things were the same across the piece, so that no matter where you were on the board, if you were a patient, the same types of advice and support were given to you. So we spent a lot of time doing that, and that was a collaborative process. So Dr. Peters was used, I think, to being a single-handed ICD in Ayrshire and Arran. So, you know, had quite fixed ideas about how she wanted things done, and didn't really understand why, if she said something that wasn't done. Now, there's no reason why it couldn't have been done, and there's no reason why whatever Dr. Peters wanted done, it couldn't have been done quite quickly. But the way that we operated at that time was we came together as a team, and the team in its entirety might have taken something forward. So, and that way that everybody, and there was a governance round about that. So you could do things quite quickly if you had to, but if it was a significant change in policy, we would write it up, and we would, not just infection control teams, so we would collaborate with people like ID physicians or occupational health physicians or people who normally sit around AICC, public health consultants, to give a kind of a team-wide, multidisciplinary perspective, and then we could change things or not. But, you know, that wasn't the case. Dr. Peters just would like things done her way, and it just, I could have worked around it. It was absolutely fine. We often have people who have got very great ideas, fixed opinions, but we work in a collaborative way so that everybody's doing the same thing. If you don't do that, then quite quickly people start to do very different things across the piece, and then the patients don't get the same care.
There's obviously a range of views have been offered on this, and obviously it depends on your perspective, because I think the criticism that both Dr. Peters and Dr. Redding, in fact, make is that it was the nursing people who were not open to collaborating with them, whereas you're saying that it's the doctors that are not collaborating with the nurses.
I mean, I don't like to think of it as a them and us, because it's not something I recognise currently or before. It is just everybody comes together, and we hopefully do the right thing going forward. I was fairly thoughtful about Dr. Redding's statement, because I always felt as if I had gone really well with them. Penelope, we'd worked together on a piece of work after there was an outbreak of salmonella at the Victoria Infirmary, and the government had put a piece of a guidance document together called the Code of Practice, and we worked together quite strongly in that. So I was disappointed. I was disappointed to hear that. I don't believe that's how we operated then, and certainly not now.
I think one of the criticisms that Dr. Redding makes is that she felt some of the senior nurses were really just wanting to use the doctor as a kind of rubber stamp for something that they'd already worked out.
Absolutely not.
Nope.
I mean, there would have been a time when some of the infection control doctors had what I think I've referred to as a light touch. So when I worked with Dr. Edwards in Stop Hill, he just sort of let me go on with the infection control stuff. Now I would tap his door if there was an issue, and we would approach solving that issue or incident or outbreak together. I've lost my train of thought, sorry. So I've always felt that it was a collaborative process.
Well, one of the reasons I asked you about this is that earlier in your evidence, we touched on this nurse-led idea, and you explained your view on that. In your witness statement at paragraph 155, you've actually selected as relevant a criticism of Dr. Peters for not accepting that infection control is a nurse-led service, which appears in a whistleblowing report. So if you don't think that's right, why would you select it as a criticism of her? You see that about half a dozen lines from the bottom.
Yeah, I mean, I think I'm just quoting from the, I mean, that nurse-led service thing, I mean, I know I've said that to you, but it's just not how it operates. It really isn't a nurse-led service, and I certainly never said that, but I think that was from the whistleblowing report that that I had been sent. So I pulled that out to say perhaps that she doesn't accept it's a nurse-led service, but actually neither do I. I'm not sure where that came from. It certainly...
No, I just wondered why you picked it, because the report, we know from other material, was created after interviewing a number of people in various roles, but not either clinicians or microbiologists. It was really more the management side that they were interviewed, and Dr. Inkster from infection control. So, but you didn't particularly pick that as a criticism for Dr. Peters. It's to be the bit before that about not listening to the views of others. Is that, in your view, a fair criticism?
I'm sorry, I'm going to have to ask you if you could...
Sorry, I'll reframe the question. In paragraph 155, under the part in bold, you say the points summarised which were relevant to IPCT were that she, Dr. Peters, does not accept being part of the team and listening to the views of others. Now, I think we know that Dr. Peters wouldn't accept that that was a fair criticism, but do you think it's a fair criticism?
I think I have put that in, and I wish I hadn't, because I know that implies that I think it should be a nurse-led service, but I have just literally pulled that from that report. I can absolutely assure you that at no point in my career have I considered the infection control service to be a nurse-led service.
Very well. And you finished that section by making the point that you're happy to work with Dr. Inkster. Can I ask you about a slightly different point? In paragraph 156 on page 443 of your statement, at the top of that page there, you say during meetings of the IMT, no one ever flagged that there was an issue with the quality of minutes. You see that?
Yes.
Now, is that statement not in fact incorrect? Because you're well aware of a number of occasions when people complained about the quality of the minutes.
I don't recall that. I mean, the minutes were complicated and they were being turned around really quickly, and there was a number of amendments to them, but I mean, that is a process. You know, there's a minute taken, it's sent out, any comments are received, the minutes are updated. I don't recall like a specific time when someone said to me, you need to find someone else to take minutes because they're such a poor quality. I mean, it's a fast-paced type of situation, but I honestly don't recall a time when someone said to me, really, I have significant concerns about these minutes.
Could we look at bundle 1, page 343, it's IMT minutes bundle. This is a set of minutes of a meeting you attended on the 14th of August 2019, which has been suggested as an example of this. Is that not a meeting at which there was a lot of discussion on the previous minutes of a meeting on the 8th of August?
Yes, but that would be a normal process. As I was saying, these meetings were happening quite quickly.
Can we just then scroll through the rest of it, see if there's any other reference to it? And again, maybe nothing at the end. Next page. the suggestion that's being made, I think, is that at that meeting, which you were present at, there was a lot of discussion about the minutes. And in fact, it got to the stage of Dr. Inkster suggesting that it might be a good idea to record them so that we got an accurate reflection of what had been discussed.
Yep.
You remember that?
Yes.
Now, if somebody's accustomed to these groups coming together, having a meeting, in the normal way, and then, producing a minute, does it not suggest considerable concern about the accuracy of minutes if someone's saying, well, we'll need to start recording them?
Or it could suggest that they're happening quite frequently and the pressure on the minute taker in order to turn them around and amend them was significant, and perhaps they weren't, perhaps she felt they weren't as good as they could have been. So it was a time of intense pressure, and these minutes were being turned around really quickly, and they may not have been perfect, but that is how we do things now.
Well, we can leave the minutes for the moment, thank you, and we'll go back to your witness statement. Paragraph 158, you record there the role of the infection control doctor, and you're pointing out that you had experience of working with somebody with a light touch, and now you're finding that ICDs are getting involved in a lot more issues about the environment, ventilation, and so on, and you're actually supportive of that notion. Is that right?
That was the chain of thought that I lost before. There was a time when the ICDs would have had, sorry if that's a poor expression, light touch, but laterally the ICDs are much more interested in the service, and it's actually starting to become almost like a subspecialty of microbiology, and all our infection control doctors are really pushing the boundaries of how we actually practice infection prevention and control and bring a wealth of different perspectives and experience. I'm very grateful to be in the team that I'm in at the moment, because they are continually, let's say, pushing the boundaries of what we do and how we do it.
So, and it's not a criticism of an ICD if they're not light touch and if they do want to get involved.
Absolutely not, no. I mean, they only bring benefits to patients having the ICDs, because at the moment, for example, our lead infection control doctor is trying to do a piece of work about an early warning system for our neonatal units, where she's trying to triangulate different types of data. So we have a lot of data ourselves, but we're not so good at bringing in other types of data like patient, acuity, so how sick the patients are, or staffing levels and things like that. So she's working with our healthcare scientists in order to try and work out a system for that. At the moment, our infection control doctor in the Royal is looking at the effects of chlorine systems in water, for example. So all of that brings more intelligence into the service and, let's say, only benefits patients.
I used to ask you about one other thing there. We know from other evidence that there were a lot of unhappy people on the ICD side.
Yeah.
In fact, it was actually very difficult to get anybody to take the job on because of what they perceived, at least, as a bad culture impacting on them. Did this impact on nurses at all? Were nurses leaving because there was a bad culture?
There's a natural turnover of nurses. Like I say, we have quite a big team. Nearly all of the nurses I can recall that I have worked with over the last 20 years have gone on to promoted posts. I think I've only had 2 infection control nurses that have actually gone back into wards because it wasn't for them. But all of the nurses that I have worked with and helped to train over the years, we have a natural turnaround. But that's expected. I mean, one of the key priorities for me is develop infection control nurses and doctors now that my remit is expanded so that they can go on to promoted posts or different types of posts.
Let me ask you about another incident that you record here. It starts in paragraph 159. There seems to have been a patient in the high dependency unit with quite a serious thing, this virus that you mentioned there, the metapneumovirus.
Cold.
Is this cool? But whatever it was, Dr. Peters thought that people should wear masks.
Yes.
And was there anything wrong with her saying, why don't you wear masks?
Well, there's unintended consequences. I mean, sometimes more is not more. So if you take that to conclusion, there are a lot of patients, I mean, wearing an FFP3 mask can be quite difficult. I mean, I think if you see any of the information around about nurses in ITU having to wear FFP3 masks during COVID, I know that the position is surely more is better. It's not always better, and it's not all. I mean, we work on the evidence base in the national manual, and that evidence is there for a reason.
But if on a particular instance, an experienced infection control doctor says, I think in this instance, you should wear a mask. I mean, presumably she's not doing that just to annoy somebody. She's doing that because she's formed a view in the interests of the patient.
And as I said, we would take that back to the team and we'd get the opinions of all the other infection control doctors about whether or not that was. So there are consequences with wearing FFP3 masks as well in terms of communication with patients. So a lot of people during COVID said that, so you can have errors in terms of information passing between patients and staff because of masks. So it's not that anything additional is just said, no, we can't do that. It's about following the evidence and the evidence base and then trying to do the right thing and not, and some of these things do have, like, there are sometimes knock-on effects for things.
Well, I can understand all of that in terms of process, but if you followed that line of thought, the infection control doctor comes on the scene, forms an assessment, says, I think in this instance now you should wear a mask. If the answer from the nurse is no, because we have to go through some process, the net result is the mask isn't worn. So does that not then create the kind of issue that the infection control doctors complained about, that they're being undermined by people not following what they asked them to do?
I mean, I think undermined is, I don't know that that's the right. Most of the time, if an infection control doctor says to us, we need to do X, then X is what is done. It's just sometimes when it is something. So if we put FFP3 masks on in that high dependency unit, the staff within that unit might think that that's the right thing to do. But if you go into the high dependency unit in the Royal, the infection control doctor in there might not think that's a proportionate response, so they're doing something different, and then you start to get a drift in terms of what people are doing. I know that sounds like I'm a control freak, but I'm afraid when it comes to the practice of IPC, I do like to revert back to the science and the evidence base, and I think quite a lot of my colleagues would say the same thing. So we do all of our practices based on the evidence and the science, and obviously some of this is emerging and then we change things. But I mean, that is just the way the system operates.
You want processes followed as opposed to the advice of the infection control doctor?
Well, no, just the science, and just for the same thing to be done everywhere, so that staff, if they're moving from intensive care to intensive care, know what's expected of them, what PPE to wear and why.
But the effect in a case like this would be that, at least from the perspective of the infection control doctor, they'd asked for something to be done and they were getting resistance to that.
Absolutely, I understand that.
And I think you probably pick up on a similar point in paragraph 161, where you were saying, well, there was an expectation the teams would prioritise anything that Dr. Peters felt was important. Well, you said she was a very good infection control doctor, very hard-working, concerned presumably for her patients, for the patients that came across her gaze, because obviously she's not the clinician. So what's wrong with Dr. Peters assessing something and saying, well, come on, we need to do X, and we need to do it now rather than after a long process?
And generally speaking, that's the response that she would get was, yes, this is an issue, let's see what we can do about it. But again, balancing things, the local teams have a responsibility for, a large number of patients across a diverse area. We are not limitless in terms of resource, and we do try to prioritise what we're required to provide in terms of advice to clinical teams for all patients that come across as referrals onto the system. So that's the primary function, is to make sure that everybody who is coming across on to us as referrals is nursed appropriately with the right kind of advice, and that the nursing and medical teams have the right information and support. So sometimes, as I said before, I would like to do much more. I mean, I would like to do, lots. I'd like to survey every single type of surgical infection, but that isn't possible. So it was just more about a balance of making sure that every patient had the access to the right amount of staffing resource in order to meet our responsibilities.
So I understand the perspective that you've laid out for us, but from the perspective of an infection control doctor keen to get something done, that might be perceived as people resisting from their end of things.
No, so the normal process would be that Dr. Peters would say, I'd really love to do, I don't know, surgical site infection in, I'm trying to think of somewhere we don't do vascular surgery at that point in time. So I would have a conversation with Dr. Peters and probably other infection control doctors and nurses and say, is there any chance that we can put this together and try and achieve this? And so we make every effort to meet the needs of ICDs, not meet the needs if they think that's an issue or clinical teams think an issue. We all work really hard in order to address whatever it is that's being requested of us. But I mean, sometimes, and if I had a conversation with an ICD and said, I think that's a great idea, we're doing this piece of work at the minute, as soon as that's finished, we'll go on and try and have a system and have a look and see what we can do in terms of support for that thing. That would be a process where you'd have a conversation and you come to some kind of plan in order to take that forward. So it's a process whereby you have that conversation and it's a collaborative process. It was just much more difficult with Dr. Peters in terms of having that conversation about perhaps other types of priorities and what was possible.
Do you accept that when Dr. Peters asked for something to be done or suggested something should be done, she would be doing that because she felt that was appropriate for the patients?
Mm-hmm. Yeah, but then again, you're balancing that relative risk. If you do that, you're not doing something else. So that risk is dynamic, and you do have to consider everything in the round. There is almost nothing that we can do that we don't have to, that something else won't get done. So it was about having that conversation about, I understand that's a thing. Over here, we've got another thing. let me turn this off so that I can do that for you. But sometimes the risk was greater with the other thing.
Let me ask you something else. 445, paragraph 163, this is a specific point that's been raised and has been put to you. The suggestion is that you told the nurses in infection control not to discuss issues with Doctors Inkster and Peters. Now, the way you reply to that is you say you don't say it specifically, but it might have been appropriate to direct them somewhere else. Is it possible that you did say to the nurses, don't refer things to Doctors Inkster and Peters?
That just wouldn't, that wouldn't be my normal thing to do. I think that it's entirely possible that I would have said Dr. Inksters and Peters aren't doing infection control doctor type role anymore. If you do have issues in terms of you're worried about something, there's a trigger, we need to do something a bit more, can you direct your comments to infection control doctors rather than microbiologists, which is what they would have been at that point in time.
Although you would know at that time that both of them had very extensive knowledge and experience.
Absolutely, yeah.
That might have helped.
I mean, absolutely. I mean, a normal process would have been, generally speaking, that, and that this happened in the past, that say the infection control doctor wasn't available, you would know who you could go to in microbiology and ask the question. So that's always available. So I used to work in the Royal, and it was Dr. Hood who was infection control doctor, but if Dr. Hood wasn't available, I would have gone to Professor Jones, for example, or other microbiologists within the system, and that would have been a normal process then. It has drifted away a bit in recent years, just because, as I said, infection control is becoming more of a subspecialty of microbiology. So it has changed over time, but I think it's entirely appropriate that the first point of contact for the ICNs would have been the ICDs, but that wouldn't have been to the exclusion of asking someone else for help should they have needed that. In fact, in some of the other boards, you would have to do that because we are in the fortunate position where we have ICDs that are dotted across the sectors, so there is more scope for that. So if I'm in Ayrshire and there's one ICD, I have to go to microbiology, and that's entirely appropriate.
Now, we see in 164, you're narrating there that Dr. Peters demitted her sessions as ICD, was then appointed as lead consultant microbiology. So he was a very experienced person. You said a very good ICD, got a lot of knowledge about microbiology. And the complaint then is that when she finds something she's concerned about, she sends information about it to you. And you basically say, don't do this. But is she not obliged to do it if she sees something that's of concern? Because that's a professional obligation on you all.
I mean, so if I think about microbiology in the north or the south, the north or Clyde, they would normally speak to the infection control doctor for the service and say, I have a concern about this, and I'd like you to have a look at that. We had systems where we were pulling over all of the information from the lab all the time, so the nurses were getting all of the referrals that they were supposed to get. But Dr. Peters wasn't an infection control doctor, but continued to ask for updates on things that, I mean, I wouldn't expect an ICD to go into the lab and say to Dr. Peters, I see you prescribed X antibiotic for that patient in that ward. Why did you do that?
Why not? If that was something that concerned the ICD, if they had a concern about it, they go and ask.
But you're talking about undermining that. That's their professional judgment. You know, they have decided that that patient has been prescribed that antibiotic for their reasons. So by, you know, it's not an inquiry for learning. It's an inquiry. Why did you do that? And to be fair, I mean, Dr. Peters really, when she decided that she didn't want to be an ICD, there were things that were going on and processes that had changed and matured, and she didn't have access to all of the information about perhaps what we were doing, but any other microbiologist wouldn't have asked for all of that information either. It was almost like a parallel surveillance process, and it did. So the way we felt as infection control nurses, that whatever we were doing, it was never good enough. So everybody in my team worked hard all of the time, and how that made everybody feel was like, and the narrative that comes across is that we don't care about patients. I don't have a person in my team. I don't know anybody that comes into work and doesn't have the patients as a priority in their practice. So this continual question about what we were doing was difficult to deal with.
But she's not suggesting, is she, that you don't care? She's saying there's something that concerns her and she'd like to know what's happening.
No,
and she doesn't know what's happening unless you tell her.
Yeah. No, I mean, it is, I'm just telling you how we felt. It was implied. I mean, we were doing everything that we were supposed to do. We were doing more than that. We were doing, there's other things in terms of patient management. We have responsibility for education, for monitoring how standards and policies are implemented, talking to patients. So there's a huge big remit. It's like a specialty in its own, and microbiology is in a specialty in its own. And that, generally speaking, they work independently but collaboratively, but this wasn't that kind of system. This was Dr. Peters continually challenging really what we were doing all of the time, and it was just difficult. I know where you're coming from. Surely all of it's to the good. It is, but I considered that what we were doing was good, and that I honestly think, although Dr. Peters wasn't an ICD, she probably did still want to be an ICD.
I suppose that it might come down to the point you make at the top of page 446, that people didn't feel they could ignore it in case there was something that they didn't know about.
Absolutely.
Now, is that not the same if you look at it from the other end? Is that not the same from Dr. Peters' end? She can't ignore it in case there's something you guys don't know about.
No, absolutely. I mean, that's why I said we didn't ignore it. I mean, if you look at the, I think it was the first whistleblowing report, it was clear after people had been interviewed that it was issues that perhaps, weren't in Dr. Peters' remit anymore, and she didn't have all the information, so she didn't really know what we're doing. It was, I'm trying to think. It was just more that, I'm really sorry, I can't think of a way to put that. Everything that was coming across was what was supposed to come across. We worked off the manual, and I know that that's been criticised as well, and that we stuck too rigidly to policy. Everything in the manual we were having referred to as, there were unusual things that came across, and we embraced those when they did come across, and we had IMTs, or we developed policies in order to address the issues that were being raised. But it was just a continual, ongoing challenge in everything that we were doing. And to be absolutely honest with you, that continues today.
Sorry, to be absolutely honest.
That continues today.
Lord, I'm conscious of time, slipped slightly past the scheduled possible break time.
Coffee break's approximate, Mr. Connell. I don't think you have to hit 11:30.
This is as good a point as any to pause.
Square on the button. So we'll take our coffee break now, Miss Devine. And could I ask you to be back at, let's say, 5 to 12? Thank you.
Thank you.
Mr. Connor.
Can I just take you back to something that we touched on briefly earlier about risk registers? One of the questions that some people have is, well, so what? Let's put something on the risk register. Tick. We've got it on the risk register. So if, for instance, water is in the risk register, who owns that risk? Whose responsibility is to ensure that something happens with it? Can you help us at all on that?
See, water's a difficult one, to be honest. I mean, intuitively, you would say that the management of water should be in the risk register for estates and facilities, because generally speaking, the risk is owned by people who have the ability to influence an action round about that risk. So I would say that that's probably logically the place for it. But water affects every patient in every area. So you could also, I suppose, think that in terms of, if I was the director of the North, that it might be my risk register as well, because it's impacting on my patient group. So it's not, absolutely, it's not a perfect system, but generally speaking, if I'm considering what we're putting on our risk register, it's usually something that I can have an influence in terms of an action to sort.
I suppose that the question someone might ask is, this is clearly a very well-intentioned system. It flags it up, it puts it on a record somewhere. But unless someone, in the sense of a person, is then directly responsible for making sure something happens about it, it's simply a paper exercise. Would that be a fair comment?
Well, no, I don't think that is, to be honest. So, for example, our risk register, we present that at each of the our governance committees. So, we will say we have updated the risk register. This is the scores. This is what we think is the risk. And in the risk register, it describes the risk, and you describe your current controls, and then you describe things that you might do to mitigate that risk to make it lower. So, so that's over. So there's an oversight of that at our committees and things like that.
But who actually does it? I mean, it's fine. You're reporting on it, and you're saying, here's a risk, here's something we can do.
Yeah.
Who's responsible for making sure that is done?
Well, we probably are in terms of our risk register. So if I've got a risk in my risk register, then it's my responsibility to make sure that there are actions in place and then also mitigations in place. It's my responsibility with the team to score that risk. And then that risk register goes forward to the next layer of the organisation, and then they'll review it in amongst other risk registers, and then
And do what?
And collate the ones that are the highest risk.
And then do what?
And then the organisation will make decisions about where they're going to allocate resources.
Right.
I mean, sometimes it's something sometimes it's a risk that occurs and I'm aware of it, and then I try and, within my own budget, allocate resources to try and fix that risk. It just depends. It just depends where the risk lands eventually.
Yeah. The reason I ask
it's difficult in a bigger organisation, I would say.
Yeah. We've had some evidence about something called the Board Water Safety Group, which we had described as essentially having to take collective responsibility for, oddly enough, water safety. But there wasn't a great deal of evidence of the Board Water Safety Group doing anything during any of the events that we've described, we've been considering in this inquiry. So the suggestion perhaps was that this business of reporting to a committee who noted the report and so on wasn't actually generating any positive action. So we're just sort of asking an open question about whether this is a working system or not.
I believe that the system works. It's not perfect. And I think in the bigger boards, it's harder to see some of the local risks. So, for example, the ventilation in like the burns unit, which I gave as an example, that would probably be a decision that would be made at a kind of Glasgow Royal level. It probably would never make its way up to the very top of the organisation. So in that terms, I think it's not a perfect system. I think it does work. I think in the bigger organisation, it's quite difficult in terms of filtering the right information to the right level. And I mean, that does happen.
And if you're the person that's reported whatever the point is, must be quite frustrating while it kind of works its way through processes, if it, because that to you is the immediate issue.
Yeah, I mean,
because you're closest to it.
Mm-hmm.
Yeah. I did want to ask you one question, which I think we've probably sort of touched on in a way already, which is this question of systems and processes. Because you would say, well, you need to have systems and processes and you should have them the same everywhere. The other argument is if you stick to systems and processes, you're not flexible enough to cope with the unusual or the difficult or the challenging which crops up, or not fast enough. Yeah. Is that a fair criticism?
No.
Why not?
Because we learn all of the time, we change things all of the time, we modify, we add on, we reassess priorities and resources, and take things forward. So I think although we work within systems and processes in order to make sure that the standard is the same across the board, we respond appropriately if new things occur, or, you know, I mean, it's changed so much, even just in the last 10 years. Like I've said to you, I've been in infection control for 30 years, but it's changed so much in the last 10 years, but really all to the better. I mean, every time, it's unusual for us to make a change and to revisit it, but we do respond to what's coming, different things, emerging organisms, COVID, nobody really expected that. So I think that we are learning, changing, improving all of the time. And I think you'll find that most healthcare systems would say that. I mean, you have to, it's so rapidly changing, even in terms of treatments for patients and treatments, vulnerabilities, different services. You're having to respond to that all of the time and adjust whatever it is that you're doing. So it's no, I don't accept that we're rigid and we don't move. I don't, sorry.
So am I right in thinking then that if something unusual crops up that suggests a step which is not in accordance with whatever the process is at the time, nevertheless you would just take that step if thought appropriate?
We would go back to the team, collaborate, decide what we're doing and take the actions forward. That can be done quite quickly. I meet my own team every Friday. If it was something that somebody said to us, we really need to do something about that now, then you communicate that through the system if it had any implications for the rest of the system. But things can be done quickly. It's better to do them in a kind of measured and a considered way, and make sure that you have the infrastructure to support that. But I don't accept that we had a rigidity that meant that we couldn't respond to anything.
Now, going back to your witness statement at 446, we see in 167, we're coming back to this problem. It was a problem that people didn't want to do the ICD role for reasons that they were complaining about their treatment. And people weren't prepared to step up and do it because they didn't want to do it either. And I think I suggested to you earlier, there was pretty much consensus that nobody at that point wanted to do the role because they were unhappy about how they were being treated. One of the consequences was that Dr. Peters suggested that they should have a generic mailbox. Now, clearly that had deficiencies because it didn't give you a direct contact to an appointed ICD. Was it not just a well-intentioned attempt to help in a difficult situation?
So just to go back, the ICDs and the other sectors were reluctant to step in because I think they felt that they knew their own area and they knew their own team, and obviously the ICDs in the North and Clyde knew about the issues in the South, and there was a professional, maybe an anxiety about going into an area which they wouldn't normally cover, but also with the issues within the South cohort. It might have been, absolutely, it was a solution, but it wasn't, I didn't consider it to be a great solution to the situation at that time, because we didn't know if we were emailing in whether or not emails were being picked up. If we did have an incident or an outbreak, it might have been somebody different each day that would take that incident forward, and in terms of continuity of information and knowledge, that was quite difficult. So it was a solution. I mean, it was, in my head, I was hoping that Dr. Inkster would have been back. So if it had been a long-term solution, then I think I would have had to flag it in terms, and it would have been to Tom and others about the issues around about it.
I'm going to ask you some questions now about a microbiologist called Ms. Harvey Wood. And I suspect we're going to come back over this similar ground again. But she was a microbiologist with, we've heard from her, a huge amount of experience in pediatrics.
Yep.
I think by the time she retired, she had about 40 years of it. And we also heard evidence from her that she, at the request of and with the support of the clinicians, presented material to them about her views on unusual organisms and so on that she was seeing. But it appears that you weren't happy to get material from her, from wearing your hat. Yeah. Is that right? And you told her not to do it.
I asked her respectfully if she could route some of these issues through the infection control doctors on the site. We were pulling across all the referrals into the ICNs. Dr. Harvey Wood did have lots of experience. I actually don't know her particularly well, but she would send lists of patients without any kind of context in terms of, you know, some intelligence around about what she thought this might mean or what the issues might be. And all I asked was that she had a discussion with the local infection control doctor, and then we would pick up anything that they felt was appropriate.
Should you not have been welcoming the assistance of somebody of that level of experience and knowledge?
Yeah, quite often it doubled the work for the nurses on the sites, because it would be things that we already knew about, we'd already looked at, and then by the time we come through with CHI numbers and things like that, they'd have to look all that back up again, make sure that the right actions had been taken. So all I said was quite a lot of the things that she was flagging was already on our system. We can add to the system, and that's my position.
Again, as I think we've highlighted in relation to a number of the issues, if you're Miss Harvey Wood, that might have been perceived as being received with open arms by the clinicians, but Sandra Devine saying negative things all the time.
I mean, I just don't agree with that position. We have really good relationships with clinical teams throughout Glasgow and Clyde. Quite often they would come to us if they had any concerns as well. I mean...
Yeah, but we're not talking about relationships with clinical teams, because the clinical teams seem to have a good relationship with Miss Harvey Wood. It's the relationship between Harvey Wood and you.
Well, we would have had the same type of relationship with clinical teams, so they could have flagged it to us directly.
Right, let's move on. 448, please. This starting to build to a question which I'll need to come to you later, but again, you're saying positive things in paragraph 173 about Dr. Inkster. And I asked you earlier about her resignation. That must have bothered you. But then, why did you think if you had such a good working relationship, she didn't value your opinion? How did that come about?
I don't... So during that time, I mean, Teresa was just different, and in a good way. Actually, different is good. So Professor Williams had a way of working, and Teresa had a way of working, and it was an impression that I had at that point in time. But when Teresa came back and took up her appointment again, she came to see me and just say, I think we were just different, and I had a lot of experience, perhaps, you know, it just, I don't know, I got a sense of that, but that doesn't stop you from working well. And I mean, I've worked with lots of people over times, and all are different and all have different ways of working. And I like to think that whatever happens, I can work with, you know, whoever it is. I can't remember why I had a sense of that, but I think at one point in time I did have that. I mean, we worked through it. Teresa was our lead infection control doctor. I had the greatest respect for her, and yeah.
And it would appear from your witness statement that other ICDs also looked to Teresa Inkster in light of her experience and knowledge.
Yes.
450, you're asked about points being raised by Dr. Redding. And is this another example where the ICDs want things done, but you're saying they can't be done just that simply?
Yeah, it is. Sorry, yes.
Because I suppose that this is back to process again, isn't it? That you're a great fan of processes. That would be fair to say, isn't it?
Yeah, it would.
And so in 183, you say, well, Dr. Redding sees a problem. She says, fix it.
Mm-hmm.
And the answer comes not, yes, we will, or yes, we will, but not till next week.
Mm-hmm.
But, well, no, we have to work through the following processes. So that would be perceived, at least, as people not being responsive to what an infection control doctor felt should be done.
There were things that were going to take time. So the Institute of Neurological Sciences is an old building. It was actually due to be replaced, but that's been put on hold, is my understanding. It is an old building. It has problems with the plumbing and the pipework. Still has issues that we work through all of the time. A lot of the buildings in Glasgow and Clyde are older buildings now. So what you do in a proportionate way is you say, this is a thing, what is the plan to fix that thing? But some things can't just be done immediately. I mean, they just can't be done immediately. But what you have to do is appreciate that teams within the health board are aware, they know there's an issue, and they're coming together in order to sort that issue. And that's my experience of some of these kind of bigger things that you know, there was issues in the building, but that people were coming together in order to sort these issues, because, I mean, the alternative was not to use the building. So from my point of view, all I see is teams working collaboratively with the best intentions to make sure that patients are cared for in the right kind of environments, but some things cannot be done really quickly. And that's just, unfortunately, how that is.
There's not actually any assurance they'll ever be done, because it depends what the subsequent groups think of them, presumably.
Well, the INS was due to be replaced.
In the next paragraph, 184, you're touching on something that we've had a little about elsewhere. There was an action plan following issues raised by microbiologists, and had a whole series of actions on it. Now, all I really want to ask you is, do you agree that the fact that there were 27 points of action arising from the raising of these issues suggests that a number of things needed to be done?
Yes, but lots of those were in chain, so they were being actioned. They might not have been completed, some were not started, but a lot of the points in the action plan, it would have been really difficult for like Dr. Reddens and Peter to really know what everybody was doing everywhere. So they might not have been aware like that there was a plan for the Institute, or that Jennifer Rogers had been doing the CLABSI work and the thing. So it's impossible to share all the information about everything that's going on all of the time with everyone. And that's, so I think there was things in the action plan that absolutely 100% had to be addressed. There were pockets of people, or bits, quite a lot of it, I think, if I recall properly, that things had started to be done about it. It was just that they might not have had an awareness of all the things that were already being done.
Okay, let me take you to an entirely different issue, paragraph 188, which is in 451. Now, this is an issue that arose over the signing off of a iScribe for 4B. And let's see if we can get some consensus on what the issue was. At the time that we're talking about here, Dr. Inkster was off.
Yes.
Dr. Inkster's name nevertheless appeared on the documentation when it shouldn't have done.
Absolutely, yes.
And the inference, at least, of it being there, if you're an outsider to the process, is that infers that she's agreed it when she hadn't.
Yes.
And then an approach was made to another colleague that we're not mentioning by name to sign this off, who was doing an ICD role at the time. And that person felt that they didn't have the knowledge or experience to do something of that significance.
Yep.
Do you agree with all of that? Now, we know that they went to Dr. Peters, who was their line manager, for help in this situation, and that would be an appropriate thing to do. Correct?
Yes.
So all of the supposed problem was that individual felt under pressure to sign off something that they didn't have the experience to do.
Mm-hmm.
Dr. Peters hadn't been involved, and therefore wasn't in a position just to sign it off.
Mm-hmm.
So there was nothing wrong with what either her or her colleague had done, was there?
Well, her colleague had already signed off the scribe.
I thought that they declined to sign it off because they didn't have the experience
No,
and went to Dr. Peters.
no. My understanding is that, and I'm pretty sure this is what happened. So it was a piece of work in order to bring 4B back into. I think it was to do with the ceiling tiles. So it was a piece of work, almost like a blocked piece of work to do. My understanding is that that person with Lynn Pritchard had reviewed the scribe and had responded that provided Lynn's comments were taken on board, that he was happy to sign that off. And I think that was probably a number of weeks before the contractors come on to site. And then when the contractors come on to site, Dr. Peters wasn't happy about the controls in relation to that, and she stopped the contractors working. And then the person who had initially reviewed the scribe thought that he was no longer happy to have done that. But my understanding was that scribe had been signed off.
I thought you agreed with me that the individual who'd been asked to sign it off was not happy that they had the experience to do so and had gone to Dr. Peters for help.
That was after.
Because the scribe wasn't signed off until Professor Jones signed it off, according to your statement.
I'm sorry if that's what I put in my statement, but my understanding is that scribe was signed off and then was rescinded, for want of a better word.
Hmm. I mean, you say in your statement, Dr. Peters advised Dr. Inkster was not happy to sign off. Well, okay, she hadn't signed it off. Dr. Peters wasn't happy to sign it off because she hadn't been involved, and therefore I didn't have the information. And you say here in paragraph 188, Professor Jones eventually signed off the process with me. Yep. So it must be wrong about that then, surely.
No, so what happened was Dr. Inkster had been involved in the entire process about upgrading and the work in 4B. So there had been a long process that had gone on over, I'm trying to remember how long, but it would be maybe the 2 years. So there was quite an involved process where plans were made for 4B and assessments were made about whether or not like HEPA filter could be put in the corridor or it was just going in the room. So there was a massive, there was an options appraisal. So the plan for 4B when Dr. Inkster went off had been set. So Dr. Inkster knew what the plan was in terms of the refurbishment and the work that were required in 4B. So I guess the implication that we took from that was that when the scribe work came online, which is something that's much more closer to when the work would require to be done, that Dr. Inkster would have signed off that scribe because she had been involved in the whole process up until that point. So I think the implication was that she would have been happy to sign that off. So when it wasn't signed off and we were getting some information back about why there was a problem with this particular scribe, what had happened was that we were told at that point in time that Teresa wasn't happy or wouldn't have been happy to sign that scribe off. But my understanding was that because she'd been involved in the process, I couldn't really understand why that would be the case. But it was, I think, I don't know what the conversation was, but I was told that that was Teresa's position. It wasn't that.
In any event, she wasn't there to do it, was she? She wasn't there to sign it off. So whatever you were told about her position, she wasn't physically present to sign off this document. Yeah,
but my understanding was that she was going to supervise this piece of work, and because she'd been involved, so she knew what the planning was. I couldn't think why there would be a reason that Teresa wouldn't have signed off the scribe. And I'm sorry that her signature was on that, but I honestly believe that that was an error. Before I came just a few days ago, I had a look at the number of projects that we've got in play at the moment, and we have sort of roughly between 60 and 70 projects. So there's 60 and 70 scribes being generated, you know, all of the time. It is a large process, but I honestly believe that it was a clerical error. I don't think there was any intention for that to have been the work carried forward without Teresa being there, or we wouldn't have had to involve her colleague.
Just so that I'm following, this is work that was completed in 2017?
No, it was planned work to upgrade 4B, which was the adult bone marrow transplant unit.
Right, so when was that work completed?
I think the patients eventually went back in 19. I
Right.
could be wrong.
So it's the regime which is, I think if I've got my dates right, in force from 2014, which has 4 stages in respect of new construction, but this was refurbishment work.
Yes.
So in relation to this, as I understand it, 3 of these stages would be relevant.
Mm-hmm.
Design, construction, and completion. Am I right?
Yes.
Now, presumably, you've been talking about Dr. Inkster being involved at the design stage.
Mm-hmm. Yes.
Stage 2.
Yes.
Just listening to you, if I'm following, Dr. Peters was concerned about the provisions in relation to the construction stage. Am I right about that?
Well, it was the control stage round about, I don't want to say, yeah, it is construction. I would have considered it more an upgrade rather than an actual, you know, they were doing a lot of work in 4B in order to bring the air, not ventilation, make sure the right air changes were in, to make sure there was HEPA filtration in the unit. So it was other patients that were in that unit at that time. So it was I don't mean none of the work round about 4B was small, but this was a smallish piece of work in order to seal the tiles. I think it was in the ensuite room. So there was stages of it. So the scribe, if you're doing any work in an area where you have patients, then you're required to assess the patient cohort and then put the correct controls in place in order to protect the patients who are already there. So this is a kind of scribe that is done all of the time when we're doing what I consider to be smaller pieces of work.
And the colleague who was asked to, it's a problem with using terms like sign off the scribe, was being asked to confirm that the work had been completed. No. Right.
It was the controls in order to implement the work.
Right. So what was an issue with the building, the controls during the construction phase?
Yes.
Thank
It's just construction sounds like an empty area.
Okay.
Sorry.
Refurbishment stage. Right. Thank you.
At least in your witness statement, you tell us that it was Professor Jones that eventually signed this off.
Correct.
With you. So whatever had been said previously, the arrangements for the controls had not been signed off by anyone up to that stage. Could we just move on? I suspect we don't need to go to it. I take it that when that individual and Dr. Pepe Valeraki stood down as ICDs, you were told why that was happening?
Yes.
Because I think you presumably would be party to at least seeing the emails.
Yes.
Yeah. So that would be a stage at which you were certainly aware of some of the unhappiness on the part of
Absolutely.
ICDs.
Yes.
I won't ask you about the generic mailbox again, because I think we've probably dealt with that. Let's move on to an entirely different topic in completely illogical order. If we go to 459 of your witness statement, we come to the opening of the hospital. And you, I think, had very little involvement in the sort of early planning. Is that right?
Correct.
There were others who were involved. Can we just see bundle 27, volume 7, page 9, please? Just check what this is. Yes, this is why I wanted to ask you about it, because you've narrated in your witness statement a discussion with Dr. Redding about isolation rooms. Yes. But this is a section of a minute in which Dr. Armstrong asks if infection control were involved in the commissioning group. Tom Walsh confirmed that Fiona McCluskey is liaising with Sandra on this. That would presumably be you. Yep. And Sandra advised she has nurses sitting on the groups they've been asked to be involved in, yes, which is a kind of reactive position rather than direct. You know, you wait to be asked and then you get involved yourself.
I think there is a confusion with the wording in this. It wasn't commissioning group as such. The nurses all throughout the process had been involved in different subgroups in terms of the functioning of the hospital and what they might be used for. So I think commissioning is not the correct term in this context. So
the reason I'm asking you is that there's obviously an issue has arisen as to the extent to which infection control were involved in the early stages of the planning, yes, of the building. Yeah. But you say there were some nurses who were involved at different points on different topics. Is that
yes,
right?
Yes. So obviously we had initially Annette Rankin and then Jackie Barman-Roy. So Jackie, at certain stages, would come back to us as a lead nurse group and ask questions about things that might have come up. And then we would collectively say, Jackie, in our experience, perhaps you should do this or that or whatever the issue was. But throughout the process, when they started putting together groups of people to look at specific issues, then we would put the right nurse into that group. So I think I attended the intensive care group a couple of times. I know that Pamela was heavily involved in some of the groups round about the Royal Hospital for Children.
That's Pamela Ioannidis.
Sorry, yes, I beg your pardon. Oh. And the lead nurse, who would have been Claire Mitchell, would have been attending groups. I think I was in the group about domestic service provision, for example. So there were lots and lots of clinical functioning groups set up, and whenever we were asked to get someone to attend that group, we would put someone on it. And we shared that about quite a bit in order that the infection control nurses would get some experience in this kind of process, because obviously none of us had been that involved in such a big project before.
I think Professor Williams told us that his memory is that most of the questions that he remembered coming back were about things like sinks and taps and stuff like that. Would that be fair?
Sinks, taps, storage.
Sinks, taps, storage.
Bed spacing. I mean, there was hundreds of things. I mean, you could be asked about mops, or you could be asked about, a CT scanner. It was just, it was lots and lots of different things.
Your involvement that you set out in your witness statement, we can leave that minute, thank you. At 460, you recalled a discussion about negative pressure isolation rooms, paragraph 233, yeah, where you and Dr. Redding thought there should be 2 on each floor, yeah, and that's what you fed in, but you never heard any more about it. It turned out that wasn't what was done.
We literally did not hear about that until the building was opened. So I did go to a meeting with Dr. Redding. I can't remember who else was there, but in 2008, I think there was a global pandemic of influenza. So we had experienced that and the challenges around patients, even with COVID, patients who required specific specialist care were nursed in hubs. And that's not the right place for them or cared for in hubs, because if you require the input from a gastroenterologist, you should really be in a gastroenterology ward. So when I went with the meeting with Penelope, we thought, in case something like that should happen again, that if we had negative pressure isolation rooms in each floor, then if you were a patient in gastroenterology, but you were unfortunate enough to have influenza or I suppose COVID, then you could be nursed within gastroenterology, but in the right type of room. So that seemed like a really, a good plan. I think I remember almost at the hospital opening that we were told that that wasn't the case.
Again, the reason I'm asking these questions is an issue has been raised about how central infection control was to planning, and it sounds as if you've got lots of people doing little things, but maybe not anyone doing big stuff.
I mean,
That be fair?
yeah. I mean, I think there wasn't a lot of experience, like I say, of a build that size. I was involved with the Beatson. I was probably one of the few infection control nurses that had been involved in an actual building going up. I don't think there was anything. I think the two ACHs had gone up, and Dr. Redding had been involved in that with the nurses in the south. But I absolutely accept, we had a lack of experience in terms of contributing to that process. But I would also say that where we were asked to contribute, that I made sure that there was an infection control resource in order to do that.
This was mainly one of your nurse colleagues?
Yes.
That was a resource you were allocated?
But Jackie Barron-Roy would come back. Like I say, she attended the lead nurse meeting every sort of couple of weeks, maybe every month, and she would come with an update. But generally speaking, the nursing part of the planning is about things like sinks and all sorts of stuff, shower curtains. I mean, I'm just trying to think of something off the top of my head, but it was more about the actual physical, the ward type layouts and environment, that type of thing.
Thank you. If we just move forward a little bit, so this is the pre-planning stage. Now we're talking about the point after the building has been handed over, and you narrate on page 462 of your statement that Professor Williams had done a walk round and certain things were identified. Do you recollect going round with Teresa Inkster, perhaps in March 2015, who queried certain things?
I don't know.
It suggested she may have made some comment about en-suites in ICU.
I don't recall that.
Did you ever tell anybody during any of these early discussions that the building was going to be naturally ventilated?
I don't recall that either.
But while we're on 462, we're now starting to turn to the things that were discovered after people were in the building, 2A and 4B in particular. I wanted to ask you about the first paragraph you've put there, because I'm puzzled, but it may simply be because I'm not understanding your narrative here. You say, I was aware that 4B was not as good as it would have been if it had been designed from scratch. When were you aware of that?
I think when the proposal was to move 4B, or to move the adult bone marrow transplant into the building, because I was involved with John Hood, with the Beatson, and even something, I mean, as I said, ventilation and water is not something that the ICNs, but I was aware when the Beatson was going up that John wanted the bone marrow transplant unit on the top floor, so that the plant work in order to do the ventilation was in the right place, so if you put the bone marrow transplant unit on the top floor, then you were able to get the infrastructure in order to do so. Putting the bone marrow transplant unit from the Beatson into the new build was never going to be something that you would be able to think about and design from scratch, and so it was never, my understanding was it was never going to be what you would have built if you'd had a blank piece of paper.
The reason I asked the question is that your insight on this seems to be perhaps better than, or certainly different from others, because we know what happened with the beats, and that people turned up, moved the patients in, then very early decided it just wasn't up to what they'd been expecting and went away again. So your insight didn't seem to have been shared by certainly the clinicians who were bringing their cohort across.
I say it might have been influenced by the fact that I knew about the meticulous planning that went into the Beatson with John, you know, and I'd had conversations. And when the Beatson went up, I did things like the ward type things and the sinks and all that kind of thing as an ICN, but I had had conversations with John at that time, so I knew that, and I knew that he had been in contact with colleagues in the USA about the design of the bone marrow transplant unit. So I was just aware that there was an awful lot of work had gone into the top floor of the Beatson, and I couldn't think why you would be able to replicate that by putting it into a building that had already been built. But that's possibly just my take on that.
Because it might be suggested that at least the objective was to try to replicate the collection of protections that were available to patients in the Beatson BMT unit in the new building. That was what people were hoping to do.
Yeah.
In terms of Ward 2A, you tell us that you first heard that there were issues with ventilation in 2015. Now, I have two questions for you about that. Can you help us at all as to how it comes to be that significant issues with ventilation were discovered as early as 2015 and go on to 2016, and yet we know that nothing significant was done of the nature that was ultimately done until way on 2018 and onwards? Can you help us why that didn't happen? Or maybe you can't.
I mean, it's difficult. At this time, I'm focusing on delivering the nursing service, and to be absolutely honest with you, the issues with ventilation was the remit and being progressed by Professor Williams. My understanding is that when he did his initial walk round with Claire Mitchell, that he did identify issues, but that these issues were rectified quite quickly, and that he did air sampling and things after that, because the kids' BMT wasn't the same as the adults. That was always planned to be in there. So I don't think you could compare the two things. So my impression was that the children's BMT was built, and yes, he had identified some issues, but these issues to a certain extent were more easily rectified than the adults.
The reason I ask, obviously, is you're aware, and you've praised the new unit elsewhere in your statement. You're aware that very significant steps were taken to rejig the ventilation and various other things in the 2A, presumably on the basis that these were thought to be necessary things to do, and yet patients were in between 2015 and 2018 being nursed in that environment. Well, other than before they were decanted to 6A.
I mean, yes, I mean, the environment, sorry, this is ventilation's not my area. The environment was what it was, and Craig had done some work in order to make it, you know, make it good. When Dr. Inkster came into post, I think her clinical opinion, and I'm sorry, hopefully I'm not putting words into her mouth, but I seem to recall that her clinical opinion is that she felt that the positive pressure isolation rooms were a better option for this group of children. And then what happened was that she communicated that to the service, and that the service put together a business case to convert 4 of the rooms that had been put in place to positive pressure isolation rooms. And I do remember there have been a progression of improvements into the area.
So you were focused on looking after the nursing service, and you weren't particularly focused on any impacts of the ventilation on the safety of patients.
Not that I'm always concerned about the safety of patients. I don't think that's fair.
No, I say you weren't focusing on that
the
issue.
ventilation was the remit of the infection control doctors, and you know, my awareness is that if anything had occurred and there was problems, that they would be the ones that would analyse that in terms of risk and would take forward any actions that needed in order to fix them.
And I think you go on in your witness statement to explain that you were involved in the process of people eventually moving back into 4B after some work had been done on it, and an analysis had been done on the sort of pros and cons of where that had got to. Is that right?
Yes.
But these were decisions taken by others, not by you.
Yes. I mean, the options appraisal thing, I remember that I think Dr. Inkster had been initially asked to go into that group, and she actually asked myself and Tom Walsh to accompany her, just to sort of, you know, go as a team and to try and present the views both of the nursing service and of the infection control doctor service in relation to the options for this group. So I did attend a meeting about the different options for BMT.
Let me ask you a completely random question, which you are asked in your witness statement, but it's one that crops up. We've heard a lot about the smell at certain times of year in the Queen Elizabeth Hospital.
Yeah.
And you say at page 466 of your witness statement that, you know, people were commenting on it. Were they right to comment on it? Was it as unpleasant as we've heard from some witnesses?
I think it was unpleasant at different points. So maybe if it was warm, I'm not aware of ever being on the site and thinking, oh gosh, that smells. I actually don't ever recall being on and really thinking that. And I'm on that site quite a lot, but I think that there would have been, and again, not an expert, but I think depending on what way the wind might be going or the temperature outside, that there are perhaps if the unit, the sewage works was busy, that there might have been peaks and troughs in terms of the odour.
At the top of page 467, you say that these issues don't cause infection. Is that a conclusion you're in a position to make?
Well, based on my reading of, I mean, although we're infection control nurses, we obviously do quite a bit of microbiology when we're completing our courses, and over the years, you know, microbiology is part of our expertise in a context. So I'm happy to say that I'm aware that smells don't cause infection.
Well, smells might not cause infection, but smells might or might not indicate a situation which may cause infection.
Totally, yes.
So maybe just at risk of repetition, the question is, I mean, we see in your statement that smells from these type of facilities in themselves do not cause infection. I mean, do you feel qualified to express a view as to whether the Shield Hall water treatment site is not, may not be a source of infection?
I would say it isn't.
Sorry?
I would say it wouldn't be.
You would say from your expertise it wouldn't be.
Wouldn't.
Right. Okay.
you can get occasions when, don't want to be too graphic, there are certain patients that you might know have an infection. For example, nurses would tell us that a patient had Clostridium difficile before the lab sample. So it's not as kind of black and white as that, but I don't believe that the Shield Hall was an infection risk as such. But I'm not saying that smells don't tell you something in a certain context.
Thank you.
Okay. That's graphic.
Let me move on through a couple of things, hopefully reasonably quickly. On 468 of your witness statement, we come back to the question of triggers, and to some extent we've already covered this. I'd just like, for reference, to ask you to look at the one email that's instanced there to Win Bundle 27, Volume 4, 322. Once it appears. Now, I suppose my only question here is this an example of a respectful exchange about this topic, triggers, where you're raising some questions about it, and Teresa Inkster says, yes, let's discuss. And she says she doesn't think it's oversensitive triggers. And you're going to discuss it again. Is this the kind of thing you're talking about?
Oh, yes. I mean, the triggers were a trial. You know, I don't mean a trial, that was a recommendation. And that happens to us quite a lot. And we put something in place and then we test it. And then we kind of try and evaluate whether or not that this, you know, that this is working. So every patient comes across on the systems, and then the trigger's supposed to be an escalation where you do a bit more, and then the IMTs when you do a bit more again. So we really didn't have, I think there was only one clinical review article that was available to Teresa that suggested triggers. So we tried them and we put them in place, but they seem to be happening quite a lot. But then but we just left them as they were because, you know, we're trialing them to try and review them. So when Teresa came back, I said, can we have a wee discussion about these triggers? And she came back and said, yeah, let's have a look at them. So I would say that is an example of a kind of respectful exchange between both of us. You know, we've put this in place. Is it working? Is it not working? Can we change it, modify it, learn? So I'd suggest that's what this is.
Thank you. I'll just ask you one more question, perhaps, before we break, and that's this, and it's probably will help us move a little more quickly through some of your statement. You're asked a number of questions about IMTs, and in relation to quite a few of these, your answer is the same. In other words, you say, well, you're asked, what do you know about this? And you say, well, the IMT is a process of discussion. You see the outputs in the IMT minutes, and I've really nothing to add to what's there. Is that fair?
I mean, that was fair, and hopefully, so I was working on the statement over the summer, and obviously there was quite a time pressure to get to, and I asked the team here if it would be okay if, rather than go through each of the IMTs, that I referred the inquiry to the contents of the minutes, just for the sake of trying to get the statement completed in time.
Well, I won't ask you any more about these IMTs, because obviously we have the IMT minutes. And I think for practical purposes, Lord, that might be an appropriate point to stop for lunch.
We'll take our lunch break now, Miss Devine, and could I ask you to be back for 2 o'clock?
Absolutely. Thank you.
Thanks, Dan.